Good afternoon, everyone. This is South African Bar Association presentation. As you are aware, the South African Bar Association hosts a weekly event at no cost to participants and viewers to improve the skill set of the legal profession. This initiative is aimed at making a fundamental contribution to developing the skill set of all and any persons who represent the South African public in our courts. Today, however, and given its relevance, we will be dealing with a public interest topic. It is my honor and privilege to introduce our eminent speaker today. Our speaker today is Professor Shabir Madhi, currently the Dean of the Faculty of Health Sciences and Professor of Vaccinology at the University of the Witwatersrand. By way of providing a brief background of Professor Shabir Madhi, I reiterate, Prof is the Dean of the Faculty of the Health Science at the University of the Witwatersrand and a Professor of Vaccinology at the University of the Witwatersrand. He completed his undergraduate and postgraduate training at the University of the Witwatersrand, qualifying as a pediatrician in 1996 and obtaining his PhD in 2003. He is a co-founder and co-director of the African Leadership Initiative for Vaccinology Expertise. He currently also holds the positions of Director of South African Medical Research Council Vaccines and Infectious Diseases Analytical Research Unit and is the Research Chair in Vaccine Preventative Diseases for the Department of Science and Technology. He currently serves as the Chair of the National Advisory Group on Immunization in South Africa and has been a member of the World Health Organization Strategic Advisory Group of Experts on Immunization since 2019. He has co-authored over 460 scientific publications since 1997, and he is leading the first 2 COVID vaccine studies being undertaken in Africa. Professor Shabir Madhi shall be addressing us today on the topic of addressing concerns, reservations, and lingering doubts relating to COVID-19 vaccines. This topic is important as many legal practitioners and parties are often faced with navigating challenging questions such as should or shouldn't I be vaccinated? A few housekeeping matters. These sessions are recorded and we appeal to participants to ensure that your microphones are muted and that your video cameras are switched off. Accordingly, during the address, all participants shall automatically be muted. If a participant has a question, simply raise your hand using the Microsoft Teams platform. During the question and answer session, please restrict questions to Prof relative to the topic under discussion and only pose such question when called upon. Without any further ado, I now hand it over to Professor Shabir Madhi. Over to you, Prof.
So thank you, Ahmed, and thank you for the introduction and the invite. So what I'm going to do over the course of the next perhaps 30-35 minutes is I don't have a formal presentation, but I'm going to just provide some thoughts on some of the big issues around COVID-19 generally, as well as when it comes to vaccines. What are the big issues around vaccines? Certainly from a legal perspective, one of the emerging issues is that the whole notion of mandatory vaccination, and in fact it would be good to get your feedback on that as well. And then what to expect moving forward with regard to COVID-19 and future resurgences in a country such as South Africa as well as globally. And bottom line is whether we can ever reach a stage where we're going to eliminate this virus, which I can state up front is extremely, extremely unlikely during the course of our lifetimes. So where do we stand with COVID-19 in South Africa? So South Africa, despite constituting less than 5% of the African population, accounts for more than 40% of all of the cases that have been documented, as well as 40% of all of the deaths that have been documented on the African continent, despite constituting less than 5% of the African population. And that doesn't mean that South Africa has necessarily been disproportionately affected. The reality is that the amount of testing that's available in most other African countries is nominal compared with what we've got available in South Africa. And even then, South Africa, as an example, only does about 1/14 the amount of testing compared to a country such as the United Kingdom. So although we do the most amount of testing on the continent, we lag behind when it comes to doing testing, the rate of testing compared to many other high-income countries. Now, the reason why all of this is important, it obviously has got implications when it comes to being able to quantify the magnitude of the problem. So based on sero-surveys, as an example, that have been done in South Africa, sometimes in select populations, other times in a general population, and most recently Discovery using the excess mortality data, which I'll speak to in a bit detail, that's provided by the South African Medical Research Council. Discovery, more of a sort of rudimentary back of the envelope calculation, basically estimate that right now, pretty much towards the peak of the third wave, where it's pretty much subsiding in most parts of the country, that close on to 70 to 80% of South Africans have been infected with the virus. That obviously is a far cry from the about 4.5 million cases that have been documented through our healthcare facilities. And the reason for that, again, is multifactorial, including issues around access, but also that the majority of infections that do occur due to the virus SARS-CoV-2 are either asymptomatic, so individuals won't even know that they are infected, or individuals who have mild self-limiting symptoms, not really motivating them to actually come forward for testing. So in all likelihood, rather than 4.5 million cases of people who have been infected with the virus in South Africa, I think that figure probably now sits closer to 40 to 45 million. And we're currently planning on doing some additional sero-surveys. So when I'm talking of a sero-survey, I need to remind myself I'm talking to lawyers. When I talk of a sero-survey, what I'm referring to is that we test for antibody. And the presence of antibody doesn't tell us that someone is currently infected, but it tells us that someone has been exposed to the virus in the past. The one problem with that antibody is that sometimes there's such waning of the antibody that it might pitch up with a false negative result. It's not useful at an individual level, but it is useful when it comes to being able to characterize or get some sort of an estimate what happened at a population level. So when it comes to deaths, the current estimate in terms of the number of people that have died, or at least recorded cases of COVID-19 deaths in South Africa, is in the region of about 79,000. But just yesterday, the Medical Research Council now released the excess mortality data. So this is the deaths that have occurred over and above what is expected during the course of the year, based on historical averages over the past 4 to 5 years. Now, the first thing about this excess mortality data is that there's much debate about whether all of these deaths are really COVID or not. And the short answer is probably 90 to 95% of those deaths, those excess deaths, are very likely to due to COVID. And the reason for that is that the trajectory of that excess mortality and the trajectory of the recorded COVID deaths is almost in sync. And then when you go to a province such as the Western Cape, you got close on to near complete concordance with regard to the number of excess deaths that are estimated compared with the number of actual deaths that are actually recorded. So the Western Cape probably has got the most robust system when it comes to being able to document COVID-19 deaths, and looking at excess mortality, those two are just completely synchronous. So it's extremely unlikely that in other parts of the country that there's excess mortality that is actually manifesting is not actually attributable to COVID. Now, the bad news is that when looking at excess mortality data, that number now is in the region of about 240,000 lives being lost due to COVID, not 79,000. But that places South Africa amongst the top 10, if not the top 5 countries with the highest death rate per capita. The death rate per capita now in South Africa is in excess of 400 per 100,000 of the population. There's very few other countries that come close to 400 per 100,000, and including countries, most high-income countries that have got really good vital registration systems that are able to document both excess mortality as well as actual recorded deaths. So South Africa has been massively affected compared with most other middle-income countries, even compared to high-income countries. And this has occurred despite us having gone into repeated levels of restrictions. And if those repeat levels of repeat restrictions were actually impactful, we wouldn't see this high percentage of the population having been infected. We wouldn't see this large number of deaths that has occurred. If you take a country such as New Zealand as an example, an island nation that was able to close its borders to the rest of the world, essentially, in that country, they were able to contain the spread of the virus. And when you look at excess mortality, they don't have any excess mortality. They've got a nominal number of COVID-19 cases, largely because they've got systems in place where from the early stages of the pandemic, they were able to contain the spread of the virus. Unfortunately, in a country such as South Africa, it was always going to be near to impossible to be able to contain the spread of the virus. So these restrictions, the only purpose they really serve is to prevent overwhelming of healthcare facilities, because if you slow the rate of transmission, the same number of cases will eventually transpire, which is pretty much what has happened in South Africa, but it's spread out over a longer period of time. So it's less impactful in terms of needing to open up, free up, or have beds available in the facilities. So the only real reason for us to go to higher levels of restriction is not because we get an increase in number of cases, but rather that because our healthcare facilities are being threatened to be overwhelmed. Now, that raises another big problem. And what we face in South Africa with this current resurgence, the third wave, is that what's currently being experienced, and this started, in fact, from November of last year, is that the provinces are behaving differently when it comes to the start of the outbreaks, of the resurgences. As an example, with this current resurgence, it started about 3 to 4 weeks ahead of, in Gauteng, it started 3 to 4 weeks ahead of where it started in the Western Cape, in KwaZulu-Natal. And right now in Gauteng, we're pretty much going right towards the tail end of this resurgence, whereas in the Western Cape, they've just peaked over the past week or so. In KwaZulu-Natal, they're still probably about 2 to 3 weeks from peaking with this current resurgence. So marked differences across the province as well. So that is really where we stand currently with COVID-19. Now, what to expect moving forward would largely depend on the issue around vaccines and exactly what vaccines are able to accomplish, what vaccines aren't able to do. And then it comes to the issue as to what the virus eventually decides to do. So what we've experienced in South Africa over 3 resurgences, we've had 3 very different variants that have circulated. There was an original virus that circulated. Then we had a beta variant that dominated, and a beta variant essentially was somewhat resistant to the antibody that was, the antibodies is sort of what's produced by the body when you're exposed to an organism. The beta variant was largely resistant to the antibody that was induced by infection due to the ancestry virus, and consequently, previous infection didn't really protect against reinfection due to the beta variant. But that is in protecting against infection and mild disease. In all likelihood, despite it not being protective against mild disease, previous infection very likely, both for the beta variant as well as moving forward with any other variant that arises, past infection will protect or provide significant protection when it comes to severe disease and death. So if people have recovered from COVID-19, you're in a much better space than people that are unvaccinated and that have never had COVID-19. Because you've developed some level of immunity, which even though not adequate to protect you against infection or mild illness, would provide reasonably good protection, or at least reduce your risk of developing severe disease, probably in a region similar to what we observe with vaccines, which is in a region of about 80 to 90%. So talking about vaccines, now the big issue is that certainly when we started looking at vaccines, and a year ago, when we were talking about COVID-19, there was this notion that we would get to what we call herd immunity. Now, what herd immunity effectively means is that there's so few susceptible individuals in the population that even if there's one imported case into that population, there will be a complete interruption in terms of the chain of transmission of that particular case. Because the majority of people have become immune, so they become resistant to being infected, so they can become vectors for further transmission. Now, when we started off with this virus, based on our understanding of the average number of people that were infected by a new case, we estimated that about 2/3 of the population needed to develop immunity, not against developing severe disease, but rather immunity against developing infection due to the virus. And there's a big difference between just being infected with the virus and ending up in hospital. Like I said, the majority of people, 50 to 60% of people that are infected with the virus will never know they've been infected because they wouldn't have any sort of symptoms. So that was our estimate for our original virus. Since then, with the Delta variant, which now dominates globally, making up more than 90% of the cases in South Africa as well, the Delta variant is about 2-fold more transmissible than ancestry virus that circulated. And the new threshold that we would need to reach in terms of immunity against infection is that about 85% of the population would need to develop immunity against infection. And unfortunately, the current vaccines that we've got, none of them come anywhere close to providing 85% protection against infection due to the Delta variant for a number of reasons. A part of which is that there might be waning of antibody over time, but in addition to which the Delta variant also has lower susceptibility to the activity of the antibody that is induced by the vaccines. For the Delta variant right now, when it comes to protection against infection and mild disease, the estimate is that the effectiveness of the vaccine is in a region of about 50%. So even if you were to vaccinate 100% of the population, you're not going to get anywhere close to 85% of the population having developed immunity against infection. But even with the 50% risk reduction of developing infection and transmitting the virus, which is pretty much what has been shown for the Delta variant, over time, that materializes into significant amount of interruption of transmission of the virus. It doesn't get you to the herd immunity threshold, but even a 50% lower likelihood of an individual that has been vaccinated to transmit the virus compared to people that are unvaccinated, over time results in significant diminished activity of the virus in the population. Now, in addition to that, the main goal of vaccines, and this has been the legacy of vaccines, we've never ever in the history of vaccines since the late 1800s, in fact, some people would say since the 1600s, have we ever developed a vaccine specifically to prevent infection with any virus or bacteria or any other pathogen. Or else we would be having vaccines against viruses which simply don't cause much severe disease in humans, as the common cold virus. Some of the other coronaviruses in humans that have been in humans since, in fact, more than a century. We don't have vaccines against those because they don't cause severe disease. So we're not really bothered by them. So vaccines have never been developed specifically to prevent infection. Always have been developed to try to minimize suffering, to reduce death, and to protect people from severe disease. But when vaccines are able to protect against infection, that's a bonus. And for some vaccines, they've worked. One has been miraculous in terms of the number of lives that have been saved, because vaccines are also some vaccines are also able to prevent infection. As an example, measles vaccine. Although measles hasn't been eliminated, the use of measles vaccine globally each year prevents roughly about 1.5 million children from dying. Despite not 100% of children, only probably about 70 to 80% of children are actually vaccinated against measles, simply because the vaccine has been so powerful in terms of being able to reduce infection due to measles, not just severe disease. So again, an example where some vaccines can take you to the threshold of getting to herd immunity, but right now in the history of vaccines, there's only two vaccines that have ever, diseases that have ever been eradicated. And that is smallpox and rinderpest, which is a disease that occurs in animals. Now, when it comes to protecting against severe disease, unlike the risk reduction, the modest risk reduction for mild disease and infection, the vaccines across the spectrum are able to reduce the risk of developing severe disease by more than 90%. And there is a range, 80% in people above the age of 70 and those with other immunosuppressive conditions, and as high as 100% in people under the age of 50 without any medical conditions, underlying medical conditions. And these vaccines are similarly, some vaccines are better than others when it comes to protecting against mild disease and infections. As an example, the Pfizer vaccine certainly is much better than the Johnson & Johnson vaccine in protecting against mild infection, especially after 2 doses of the Pfizer vaccine. But when it comes to protecting against severe disease, these vaccines are much more, they're converging in terms of the extent to which they're able to protect against severe disease. There might be some difference, but not as marked as when it comes to being able to protect against infection and mild disease. So as a general statement, irrespective of which variants are circulating, including with the Delta variant, what we observe for the Pfizer vaccine as an example is that protection against severe disease is in the region of 90% and above, whereas protection against mild disease and infection is only in the region of about 50% against the Delta variant. So summary of that, vaccines have been a phenomenal success in protecting against severe disease. And when we started out on this particular path to get vaccines developed, the threshold that was set by regulatory authorities for the licensure of vaccines was not 90% protection. They were happy to make vaccines available for use in a population if the vaccine had 50% protection against any severity of COVID-19 illness. And when we saw the initial results, I think that created a sense of euphoria, and everyone started to expect much more vaccines than what vaccines generally are able to actually deliver. And that obviously has been compounded because of the issues around the evolution of the virus, where the virus has now become more transmissible. And as an example, the beta variant that circulated in South Africa in November becomes almost completely resistant to some vaccines, the antibody that's induced by some vaccines, such as the AstraZeneca vaccine, although the AstraZeneca vaccine still maintains protection, high levels of protection against severe disease due to the beta variant, as was recently shown in the study in Canada. So that now brings us to the issue of, I mean, you asked me to speak about the reason why people are hesitant, and I think among this group, each individual would have their own idea as to why people are hesitant. So I'm not going to go through the number of different sort of issues that are raised. You're welcome to ask questions. I'm happy to address those questions. But it does take us to the next issue about mandatory vaccination. So as I mentioned, vaccines work extremely well against severe disease. So from an individual level, anyone that is not wanting to be vaccinated, I think they just missed the boat, essentially. And I think there's place for there to be consequences on people who end up with severe disease, end up in hospital, that have chosen not to be vaccinated, including, as an example, the medical aids are basically tailoring the products based on whether people have been vaccinated, as well as tailoring the premiums, specifically when it comes to being hospitalized for COVID-related illness, as well as subsequent sequelae, which is known as long COVID, that does occur. And just to mention that vaccines actually do reduce the risk of long COVID, even with a 50% reduction in protecting against mild infection. People that are vaccinated are substantially less likely to end up with long COVID, and especially even if they get infection after being vaccinated. So the issue of mandatory vaccine is more in the context of not individual protection, because at the end of the day, the Constitution allows people to have complete control of their own bodies and to choose what type of interventions they're wanting to submit to. But the reason for mandatory vaccination is more about the public health value of vaccination. So despite vaccines only having a 50%, reducing the risk of an individual transmitting the virus by 50% compared to someone that is left unvaccinated, that 50% over time results in an enormous reduction in transmission of the virus, as well as the risk of other individuals. And the other individuals that we're particularly concerned about is that group of individuals that have got underlying medical conditions, people above the age of 70 as an example as well, who despite having been vaccinated, the vaccine doesn't confer 100% protection against severe disease in those individuals. It confers 80% protection. Now, they still remain susceptible to developing severe disease despite having been vaccinated. And their chances of being infected is greater if they become exposed to someone that's unvaccinated compared with someone that is actually vaccinated, because a person that's vaccinated is less likely to transmit, is less likely to become infected in the first place, and less likely to transmit the virus. So people that remain unvaccinated, unfortunately, from a public health perspective, do pose an additional risk compared with people that are vaccinated who still are not completely protected from infection due to the virus because of some limitations around the vaccines. So I believe certainly in places where people work in large crowds, even in universities as an example, or healthcare workers. And healthcare workers is a good example, where when healthcare workers choose not to be vaccinated, firstly, they pose a threat to their other colleagues, and they usually work in very densely populated settings. In addition to which, the healthcare workers that choose not to be unvaccinated, if they are infected, they also pose a risk to the patients that they're actually caring for. And I believe there's grounds for legal liability against a healthcare worker that chooses not to be vaccinated, that passes on an infection to a patient that they're looking after, and particularly if those patients are immunocompromised individuals, they have taken the precautions of getting vaccinated, but the vaccine doesn't provide them 100% protection, and consequently they become infected by this irresponsible healthcare worker, I would say, who chose not to be vaccinated, who now passes on the virus to them. And our hospitals, unfortunately, have been disastrous when it comes to what we refer to as nosocomial transmission. People that come into hospital without the virus ending up getting infected in the hospital because of transmission between patients, as well as because of transmission between healthcare workers and the patients. So I believe there's a strong case to be made for mandatory vaccination, at least at the level of the workspace. And certainly even things such as if people are wanting, and I think the type of restrictions or penalties that are being imposed in countries such as France and the United States, where people that are unvaccinated are unable to gain entry into indoor spaces, such as restaurants, bars, clubs, that makes perfect sense. Because in those spaces, people are not wearing face masks, and they basically, if you're unvaccinated, you pose twice the risk of transmitting the virus to other individuals in that space compared to people that have actually elected to be vaccinated. So finally, what can we expect of COVID-19 in South Africa when it comes to resurgence? And unfortunately, there's no sort of crystal ball that will tell us the future. What we can probably say with a high degree of confidence is that the next resurgence, although the timing of it is unpredictable based on what we experienced in the past, it's probably going to be about 4 to 5 months from now, so sometime in November, January, but it also partly depends on how open society becomes and how many people get vaccinated. But in addition to that, the next resurgence should end up with much lower rates of severe disease and hospitalization. We shouldn't face what we've experienced during the course of the first 3 waves for 2 reasons. The one reason being, as I mentioned, a high percentage of the population have already been infected with the virus, and that does not necessarily confer too good protection against reinfection due to new variants that might start circulating, but it does confer high levels of protection against severe disease and hospitalization and death. Probably, if you ask me to guess, it's probably at least above 80 to 90, in fact, probably above 90%, similar to what vaccines induce in protecting against reducing the risk of hospitalization and death. So yes, we will experience another resurgence, and there'll be another resurgence after that, and that becomes irrespective of whether we vaccinate 80% of the population. And a good example of that is what's happening in Israel right now, what's happening in the United Kingdom. Those countries have now been able to vaccinate close on to 90% of the adult population. And despite vaccinating 90% of the adult population, both the United Kingdom experienced a resurgence, which is now which is pretty much on a decline. And that decline in the resurgence of the Delta variant occurred at a time when they actually declared Freedom Day. They allowed for an opening up of society. You see what's happening in the soccer stadiums. You see that Arsenal hasn't changed much when it comes to the manner they play soccer. But essentially, they've been allowed to open up society. And they faced a resurgence, and the resurgence didn't go out of control when they opened up society, simply because people were vaccinated and protected against severe disease. They documented much higher number of cases than South Africa, but it didn't materialize into people ending up in hospital and dying. And the United Kingdom is an example of a country that has pretty much dismissed the notion of herd immunity. They've gone on a strategy of accepting that vaccines are out there to protect lives, to prevent severe disease, and people will continue getting infected irrespective of what percentage of the population have been vaccinated. Israel, similarly, basically, they're seeing a resurgence. They're seeing increase in hospitalization and death. But there's some sort of unfortunate, irresponsible, or I would call uneducated reporting. So some people argue, well, 67% of people that are now being hospitalized in Israel have been vaccinated, fully vaccinated. That is true, but when we reach the point when 100% of the population have been fully vaccinated, be rest assured 100% of the hospitalizations that occur will be in vaccinated people as well. But obviously, you can't see that as a measure of vaccine effectiveness. You need to look at it in relation to an unvaccinated population, or you need to look at it in relation to actual rates per 100,000. And when you look at the rate per 100,000 of hospitalization that's taking place in Israel right now, it's not more than 10% compared to what it was when there was no vaccination taking place. And that is despite much more transmissible virus circulating. So, like I said, so the other factors that will determine the magnitude of the next resurgence also depends what happens with the virus, whether it continues mutating, whether it becomes even more transmissible, or whether it becomes more transmissible as well as become more immune evasive, where it starts evading the immune responses that are induced by the vaccine as well as past infection. But this immune evasiveness is a relative term. It seems to work in allowing the virus to continue replicating, but there's another arm of the immune system, not the antibodies, there's another arm of the immune system which seems to be more responsible for protecting against severe disease. And that remains relatively intact, despite the type of mutations that are occurring in what everyone knows now as a spike protein. So the vaccine coverage would be important. The virus that starts circulating in the future, if there's further evolution, would determine it. The extent of past infection will also be a significant factor when it comes to determining what the magnitude of the next resurgence will be. So we will experience another resurgence, but it would be highly, highly surprising, touch wood, that we would see as large number of people die and as large number of people end up in hospital compared with what we experienced during the course of the first 2 waves in South Africa. So let me pause there and happy to take questions.
Thank you so much, Prof. Your address was exceptionally informative. I'm now going to open up the session for a brief question and answer session. Just bear with me in that regard. All right, Prof. I have now opened the platform for a brief question and answer session from the participants. You mentioned, correctly so, that your address today is to legal practitioners. In that regard, remember, Prof, you have a constitutional right to remain silent. By way of a reminder, participants wishing to pose a question simply using the Microsoft Teams platform. I shall commence the question and answer session, Prof, with a comment which would require your submission in that regard and a question to follow. My comment requiring your submission is as follows. There is a global debate amongst experts regarding whether vaccine mandates are ethically justified. The debate has, of course, extended to South Africa, where our human rights are fundamentally enshrined within the Constitution of the Republic. In a recent article I read, bioethicist Moodley argued that South Africa's constitution requires any limitation of rights, such as a vaccine mandate, to be proportional to the purpose of the limitation, in this instance protecting public health. Accordingly, it was submitted that given the high risk of public health, a vaccine mandate is justified. However, the Constitution also requires that the least restrictive means must be employed when limiting rights. There is no doubt that COVID-19 poses a big threat to public health. However, it is my submission that the vaccine mandate is clearly not the least restrictive means to protect public health from COVID-19, but rather explore public avenues such as incentivizing vaccines, rather than using the law as a rigid hammer to batter individuals into compliance. What is your submission in that regard?
Yeah, well, so I didn't venture in trying to argue with the legal fraternity about the law around it, but I think I can take on the ethics part of it. And I guess it's an issue of individual rights versus the community good. And that is from a public health perspective. And yes, people do have, and I wouldn't say that we need to make vaccine mandatory, but at the same time, there needs to be consequences and there needs to be limitations placed on those individuals that choose not to be vaccinated. And it's analogous to people having a choice. If you want to drive a car, you've got a choice of, well, you don't really have a choice, in fact. You need to have a driver's license to be able to drive a vehicle. But people can claim their rights to individual freedom and drive a vehicle without a license, and they get punished for that. So when it comes to people choosing not to be vaccinated, certainly we should allow for that right to be upheld, but it comes with consequences. And I mentioned some of the consequences, including restrictions that are placed on those individuals in terms of how they engage in society, the spaces they're allowed into, the spaces they're not allowed into, and what's expected of them. And what would be expected of them is that until we're in a good space where a large percentage of the population, in fact, is protected through vaccination, those individuals that choose not to be vaccinated are the ones that should be forced to continue wearing face masks. They should be prevented from entering indoor spaces where they pose a risk to other individuals. So placing restrictions, yes, I think that would be the way to go. And I don't think we're going to be able to make vaccination mandatory in South Africa, at least not in the foreseeable future, because it certainly would go right up to the Constitutional Court and be challenged. But I think it's an issue of getting a balance, getting under people to understand that when it comes to the least restrictive measure in which we can get the pandemic under control, in fact, the least restrictive measure, the one that does least harm to to society is vaccination. It's the only sustainable manner in which we can get this pandemic under control and prevent people from dying and reduce the risk of people dying. Everything else is not sustainable. Continuing with repeat lockdowns is affecting the livelihoods of people. So when people choose not to be vaccinated, remember, it's got consequences. It's got direct consequences. It's got societal consequences. It's got consequences for the economy. Can South Africa continue going from one level of restriction to another every few months? Well, if a large percentage of the population choose not to be vaccinated, that would be the space that we are in. Fortunately, it's not the vast majority of the population that choose not to be vaccinated. In fact, when we talk of vaccine hesitancy, I think it's an incorrect term. I think the more correct term is that the anti-vaxxers, which is on the one hand, and on the other hand, there's the issue around vaccine confidence rather than vaccine hesitancy. And there's a distinction between the two. There's some hesitancy amongst people that are not confident about vaccines, and that needs to be addressed. But the major reason why people have not been vaccinated in large numbers, despite now there being security of supply of vaccine, is an issue of access. So government, when it decided to introduce systems which simply were not suited for purpose in South Africa, such as the EVDS system, the electronic vaccine data system, and then when they made decisions about not allowing people that are not the medical aids to be able to make use of the private sector, those were impediments to rolling out the vaccine, not expediting the process or not facilitating the process. So many of those issues have been addressed. I think access has become much better now, but government needs to do much more. It needs to take vaccines to the people rather than expecting people that are doubtful about vaccines to come to facilities. And some people simply don't have the funds, even if it's 20 or 40 rand to travel to a clinic and go back home, they don't have that funds. So go to the SASSA pay points, as has been done in Limpopo, as been done in the Western Cape, and you will find that 95% of people in those queues, when they're offered the vaccine, they're taking up the vaccine.
Thank you so much, Prof. That answers my question.
Ahmed, I'd like to ask a question.
Sure. Can I just, Bart, can I just ask a second question, and then I'm gonna hand it to you. My second question pertains to the COVID-19 variants. Albeit the fact that we are aware that there are different variants. As we have seen within the media, the latest COVID-19 variant is a variant called the Lambda variant. Within your address, you stated that the Delta variant, and you mentioned the Delta variant and the Beta variant has an effective rate of around 90%. A reasonable assertion is drawn to the fact that the so-called Lambda variant is completely different to the Delta variant. Now, my question is pertaining to this Lambda variant. In lieu of the various conflicting media reports, my question to you is, has the Lambda variant been discovered within South Africa or not?
Well, at the moment, it hasn't been documented in South Africa, but we do a limited amount of testing and even less sequencing. So it might well be prevalent in South Africa, but at a very low rate. Currently, the sequencing data over the past 2 weeks, as an example, indicates that probably close on to 92%, 93% of all of the cases identified over the past 2 weeks within the confines of limitations of where samples are coming is actually due to the Delta variant. But there's another variant that's sort of on our horizon in South Africa already, which in fact is sort of chimeric of the Delta and the Beta variant, which is not good news, at least not when it comes to protecting against infection. The vaccines will still maintain effectiveness against severe disease. So I'm not too worried about the Lambda variant. In fact, I'm more concerned about the other variant that is beginning to evolve in South Africa. And the vaccines will still protect against severe disease due to the Lambda variant, but they might be more variable in protecting against infection and mild disease.
Thank you so much. Prof, there's a question by, I'm going to get to Advocate Ahmed Kaji. There's a question by Advocate Bart Ford. Advocate Bart Ford, you can simply unmute your mic and your video. Okay.
Good afternoon, Prof. Prof, I've got two quick questions. The one is, there appears to be a lot of hesitancy amongst not only legal practitioners, but society at large to make themselves available to be vaccinated. And I think the concern is that it has to do with the fact that, and you can confirm whether this is so or not, there hasn't been sufficient research done in terms of the vaccine that's being administered. Whether or not the vaccine that's being administered can in fact sufficiently protect against the developing variants that we find at the moment? So that is the first question. And then the second question is, there appears to be concern that there may be a lot of side effects and that there's not sufficient research being done pertaining to the side effects that comes with the vaccines. Do you have any thoughts around that?
Sure. Do you want me to answer that, or you want to take other questions and answer them as a group?
Prof, I think you can answer that, and then we'll move to the next question. Thanks.
Yeah, so I think when we talk about there being a large percentage of the population as vaccine hesitant, like I said, yes, the people that are vaccine hesitant, and certainly the anti-vaxxers even more so, and those are two very discrete groups of individuals, they're much more vocal compared to the people that just accept that vaccines are a good thing. And they're obviously much more vocal on social media in particular. And some of the concerns are justified, and I'll speak to those. So the first issue is around not enough research being done on vaccines. I've been involved in doing research on vaccines for the past 25 years. And generally, the reason why what is usually done in a 10.5-year period was accomplished in a 10.5-month period, which is really a spectacular achievement. It's not because any shortcuts were taken. It's multifactorial. First and foremost is that the reason why it takes 10.5 years to complete vaccine trials is because there's different stages of trials. You start off small, go medium, and then go large to show the vaccine actually is safe and it works. And that usually takes place in series. And the reason why it takes place in series is because companies usually need to make the investment, and they need to be sure that this vaccine is going to succeed before they take it to the next level and to the next level. When you go to phase 3, those studies cost in the region of $500 million to $1 billion when you're enrolling 30 to 40,000 people into those studies. So companies are wanting to have some level of certainty that this vaccine is going to work. So they spend a lot of time in phase 1, phase 2 before they make this leap into phase 3. So the funding, and in addition to which, what we experienced with COVID-19 is that people that were working in all other types of vaccines against other diseases, even people that were involved in the cancer field, where messenger RNA is used as a therapeutic, not as a vaccine, everyone came together because all of a sudden government said, listen here, you have billions of dollars, do what you can, get this done as quickly as possible. And we don't want you to do things like in the past. We want you to do things in parallel, but you need to have the appropriate safety, the safeguards in place. And the people that are responsible to ensure the oversight and that there aren't any shortcuts is the regulatory authorities. So when it came to the regulator, and government was making this investment at no risk to the company. So if the vaccine failed, the company wasn't going to lose anything, government wasn't going to benefit. And that was the bottom line of Operation Warp Speed. And the same thing happened in the UK, the same thing happened in Germany. So when it comes to the issue about regulatory oversight, so I've been involved for 25 years in vaccine trials in South Africa. When we do vaccine trials, we expected, so firstly, it takes 3 to 4 months before the regulatory authorities provide adequate feedback, whether you can go ahead. And then every 6 months, you need to report back to the regulatory authority. SAPRA, as an example, set up a special committee just to review protocols for COVID-19 vaccine trials. Rather than taking 3 to 4 months, the reviewers were asked to provide feedback within 2 weeks without any shortcuts. The companies, the sponsors were still meant to respond to comments from the reviewers. And then in addition to that, SAPRA insisted that you're no longer going to report to us every 6 months. You need to report to us every 2 weeks, literally every 2 weeks. And that's what was expected. And that's what we've done in this. So the intensity of regulatory oversight, not just in South Africa, but globally, has been unprecedented. And that was all because we wanted to ensure that no shortcuts were taken, that we weren't compromising on getting a good readout when it comes to the safety of the vaccines foremost, and then the effectiveness, efficacy of the vaccines. So when you do a study of 30 to 40,000 people as an example, you're only able to identify difference between the vaccine group and the control group if the incidence of that side effect is in a region of maybe 3 or 4 per 1,000 people. That a study of 30,000 people will be able to identify that sort of rare side effect of that sort of rate of side effects of the vaccine. The type of side effects which gets media attention, such as clotting of the large blood vessels, the central venous sinus thrombosis, The frequency of that side effect is 1 in every 250,000 people. 1 in 250,000 people. You'll never do a vaccine trial that includes 250,000 people. In fact, the frequency of side effects for all other vaccines that we use, of fatal side effects, the 1 in 250,000 is not even fatal. So if 4 out of 1 million would develop that particular complication from the AstraZeneca or Johnson & Johnson vaccine, of which 1 out of the 4, so 1 out of 1 million will die. Now, the rate of being struck by lightning in South Africa, as an example, is 1 in 350,000. In Johannesburg, it's closer to 1 in 250,000. So when we talk of side effects, unfortunately, we lose perspective in terms of risk-benefit ratio. Like I mentioned earlier, the number of people that have died in South Africa per million of the population up to now due to COVID-19 is not 4 per million, it's 4,000 per million. So yes, there are safety issues with vaccine, and certainly the vaccine studies won't be able to identify extremely rare side effects. But certainly from a risk-benefit profile, if you're taking a chance of driving on the roads in South Africa or just living in South Africa, forget driving on the roads, your chances of surviving is much greater after having taken a vaccine than just being in South Africa. With regard to the question of protection against different variants, like I said, the vaccines are variable in terms of how well they protect against infection due to different variants. And between the vaccines, again, they differ in terms of how well they protect against infection. But when it comes to protecting against severe disease, for the major variants of concern that have arisen up to now, the vaccine has been consistent in still providing extremely high levels of protection against hospitalization and death.
Thank you so much.
Thank you, Prof.
There's a question from Advocate Ahmed Gaji. Advocate Ahmed Gaji, you can simply unmute your mic and your video.
Okay, can I ask the following question, Prof? There's actually 3 questions. One is elections. When will it be free, fair and safe for us to have elections? I mean, you must have been following the debate. 2, why are so many health professionals, including some very prominent health professionals, so anti-vaccine? And I think that's a part of the reason that's driving this vaccine hesitancy among the population. 3, Prof, I've been following both yourself and one of your more flamboyant colleagues who I won't mention. And I can tell you, Prof, I've seen some of the predictions he's made and a number of times he's got it wrong. Now, personally, I'm not an anti-vax. I just had my 2nd shot today. But I can tell you personally, as far as I'm concerned, and maybe it's because I'm a lawyer, he doesn't really fill me with confidence anytime he speaks. So, that's just some of the comments I have. Thank you, Prof.
Okay, so I won't comment on the 3rd comment, but I will comment on other 2 issues. So in terms of elections, like I said, right, we probably, it would be safe to have elections in South Africa when we got at least 80%, not of the population, but 80% of people above the age of 60 and 80% of people above the age of 35, especially those with underlying medical conditions vaccinated. If we're able to get that group vaccinated, and that doesn't come up to 20 million or 40 million, in fact, in South Africa, that comes to about 15 million, those sort of high-risk groups together with people above the age of 60. If we can get them adequately protected against being against hospitalization, not against being infected with the virus, then we're in a good space to be able to go into election mode. So the timing of the election should be, and when I made my submission to Judge Mosenga about this whole issue, that is exactly what we said, is that the timing needs to be determined by when we predict we'll be able to get to a certain threshold of having the high-risk groups vaccinated. And all indications are that we should be able to do that, not by October certainly, but certainly by the end of the year. So I think what was actually put forward as a proposal, and that is for elections to be delayed until February, basically is where we should be heading towards. I remember the majority of people that end up voting, and it's not really the voting itself which is a problem. So it's not the election day that's a problem. It's the lead up to the election day, which is going to be the super spreader events. The election day, the sort of what happens at a polling booth, and that's much more controlled. You can minimize the risk of people getting infected. You can insist on people wearing face masks, physical distancing. But the lead up to that elections is where you get the super spread events when political parties are campaigning on the streets, in indoors, and that is where the virus is going to spread very rapidly. And that is what we can't allow. So if there was absolute restrictions in terms of mass gatherings and political parties not being able to canvass for votes in public spaces, where there would be mass gatherings, then we can have an election in October without any problem. But it comes with restrictions in terms of the type of activities that can be allowed to the lead up of to the elections. When it comes to health professionals and what I would really consider irresponsible utterances, I mean, I would strongly advise anyone on this call and anyone in South Africa to avoid coming to me for a cardiac surgery and to avoid coming to me to learn about sports medicine, as an example. I would strongly discourage that. And it comes to a situation where, unfortunately, what we've experienced, not just in the healthcare fraternity, but just generally, around this pandemic is that in contrast to the 10,000-hour experts, you've got a 10,000-second experts. And the 10,000-second experts tend to be much more vocal, much more reckless, completely oblivious to the consequences of what they've got to say. And it's not to say that Prof. Noakes and Dr. Vosloo have done any meaningful research, because just purely based on what they say, it's clear that they're completely misguided. They got a rudimentary understanding. In fact, Prof. Noakes, quite frankly, insists that what we've got available to us is not even a vaccine. And that defies all logic, simply all logic. It doesn't take, in fact, my daughter will tell you, who's in grade 10, she'll tell you what a vaccine is. And the notion of a vaccine hasn't changed since the 1800s, when Edward Jenner developed the vaccine against smallpox. So it's unfortunate that these things happen. And I think the Health Professional Council of South Africa, if it wasn't itself so dysfunctional, they would probably be able to actually take action against these so-called healthcare workers. Prof. Noakes decides that he's no longer registered as a medical practitioner. So unfortunately, the Health Professional Council can't take any action against him, giving him carte blanche to say what he wants to say. Dr. Vosloo is registered with the Health Professional Council, and Health Professional Council needs to start taking action, as Sama has indicated, that this needs to be done to avoid what is basically being sort of instigated by irresponsible healthcare workers.
Thank you, Prof.
Thank you so much, Prof. Prof, there's a question from Liashin. Liashin, you can simply unmute your mic and or your video.
Good afternoon, Prof. I've got 3 basic questions. My first one is, I want to know, what are the long-term risks of being vaccinated, if there is in fact any risks? Secondly, I also want to know if you've decided or opted for the Pfizer vaccine and you've taken your first shot and then subsequently developed COVID or contracted COVID, and then you need to go for your second shot. How long do you wait for that period to get your second shot of vaccination? And then also, I think there is a false sense of complacency with regards to the vaccine, in that the public is under the misconception that a vaccine is there to prevent the contraction of COVID rather than to lower the severity of the symptoms. So how would one sort of guard yourself against that false sense of complacency?
So in terms of the long-term risk, South Africa currently, children in South Africa probably receive close on to about 14, 15 different vaccines. And there's probably about 6, 7 different vaccines that are available for adults. The vaccines generally, when they do cause side effects, there's a temporal association as to when they cause the side effects. They usually cause it, in all of these vaccines I'm referring to, more than 20 vaccines that are available in South Africa. These side effects usually occur within 2 to 3 weeks of vaccination. Exceptionally, it might occur 2 to 3 months later. And that was my knowledge of that is only for one vaccine, in fact. And that was in 2009 with the pandemic flu vaccine, where they used a novel adjuvant where people started to develop narcolepsy 2 to 3 months later. Vaccines have never been shown to only start manifesting side effects months and years after vaccination, because by that time, the immune response has already taken place. The vaccine has actually been already pretty much discarded from the body because it disintegrates for all intents and purposes and is no longer there to cause harm. So, like I said, we don't have data on long term. And if we wanted to wait what the safety of the vaccines would be after 2 to 3 years, yes, we could do that, except 2 to 3 years from now, there won't be any pandemic because 100% of the population globally would have been infected with the virus. So it needs to be a calculated guess. It needs to be based on past experience. And the past experience is a majority of side effects that do occur within 2 to 3 weeks after vaccination and not months after vaccination. Right now, when there's close on to 4.5 billion people, many of whom have received vaccines 6 months ago, they're not major, there isn't any evidence, zero evidence, that they've had side effects 6 months after vaccination. The type of rare side effects I mentioned were side effects that manifested, in fact, very few days after them having been vaccinated. So I wouldn't lose any sleep on long-term effects. You're not going to turn into, in the 1800s, when they were vaccinating against smallpox, they used what is known as cowpox virus to vaccinate. And people strongly believe that the vaccine was going to turn them into cows, just like people believe that the messenger RNA vaccines is going to change the DNA. That was a belief in the 1800s, that people were going to turn into cows if they got vaccinated against smallpox. Then the issue of the value, when to be vaccinated. If you've developed COVID, you probably should wait about 2 to 3 months after having developed COVID, even if you haven't been previously vaccinated, but even if you've been vaccinated before you actually get vaccinated. The reason for that is twofold. The actual infection will confer immunity in the short term against infection and certainly against severe disease. But in addition to that, the immune responses is better if you wait 2 to 3 months rather than very soon after you've recovered from COVID. And finally, the issue about, unfortunately, the messaging around the purpose of vaccines. Politicians keep on speaking and harping that we need to vaccinate 40 million people or whatever million because we want to get to herd immunity. Unfortunately, I wish politicians read a textbook or at least had some basic explanation of what the concept of herd immunity is, how infrequent it's occurred in the history of mankind, before they make those sort of utterances, because politicians, in the way that we try to promote vaccines, does give a false sense of security and false expectations in terms of what we can achieve with vaccines. Vaccines are about saving lives. It's about preventing hospitalization, minimizing hospitalization. It's not about preventing infections. That is a bonus. So people will continue getting infected, but those that do get infected after they're vaccinated, they're at a much substantially reduced risk of ending up in hospital and dying.
Thanks so much.
Thanks, Prof. There's a question from Pascal. Pascal, you can simply unmute your mic or your video.
Thank you so much, Prof, for speaking to us today. I have one question for you. I mean, if the vaccine is as effective as it is acclaimed, and when people get vaccinated, they are protected from severe symptoms and hospitalization. My question is this: why are the authorities fixating on those who have exercised their right not to be vaccinated? Because these people pose no dangers to those who are vaccinated. Why are the authorities threatening them with consequences and sanctions? Because I think this is what is making people to think twice about vaccination. I have never seen someone being forced to stay alive. It's a matter of choice. So why are the authorities coming up with these sanctions in order to force people to get vaccinated? What is so special about this COVID-19 vaccination?
Yeah. So, Pascal, like I said, unfortunately, that is not correct. So there is the greatest benefit of vaccination at an individual level is it protects against severe disease. But like I mentioned when I was presenting, people that remain unvaccinated are 2 times more likely to become infected with the virus and 2 times more likely to transmit the virus than people that are vaccinated. So even though vaccines don't have 100% protection against infection, even when it's just got 50% protection against infection, that means that someone that is vaccinated that's exposed to the virus is less likely to become infected with the virus and less likely to transmit the virus to other people. The problem is not that person that remains unvaccinated transmitting the virus to someone else that is in the same young age group. That is not a problem. The problem is that person that's unvaccinated. They still pose a risk to the other individual that has been vaccinated, but who, because of their medical condition, doesn't mount a good enough immune response. So people that are immunocompromised, people with cancer, people with HIV, people above the age of 70, even though they're vaccinated, the vaccine, unlike in a 35-year-old person where there's 100% protection against severe disease, the vaccine effectiveness against severe disease in that group of individuals is only 80%. So so basically remain unvaccinated basically poses a risk to those people that have been vaccinated, but who don't have optimal protection because not of their own doing, but because of a medical condition that they actually are living with. So people that remain unvaccinated do pose a public health risk to other individuals, and particularly I'm not interested in the spread of the virus in the school. That is sort of meaningless to me. Children are getting infected all the time and they remain completely healthy. The problem is those individuals with underlying medical conditions and getting the infection from an unvaccinated individual for whom the vaccine is available. The whole discussion of mandatory vaccination, the starting point of that is access to vaccine. In the absence of access to vaccine, then you can't even have a discussion on mandatory vaccination. But where there is security of supply and where there is access to vaccine, people that choose not to be vaccinated, yes, they take on an individual risk, but they pose double the risk compared to someone that is vaccinated in terms of transmission to other individuals in the society who have been vaccinated but don't derive the full benefits because of a medical condition.
Thank you so much, Prof. Prof, there are a number of questions from the...
Yeah, so Ahmed, I would like to continue. I've got literally another webinar that starts at 5.
Sure. There are a number of questions from participants over the various live platforms. However, time does not permit for such, and regrettably, I have closed the question and answer session. What remains, on behalf of the South African Bar Association, we sincerely thank Professor Shabir Madhi for his informative address and his time. Appreciation to all those that have participated virtually and shall be watching this session at their leisure. These sessions are recorded, and the recordings can be found upon the South African Bar Association website, that being www.rsabar.net. I thank you.
Okay, thanks, bye.
Thank you, Prof.